physical inactivity, obesity, high cholesterol levels. Because diabetes is a progressive disease.
Welcome to the first episode of the Live It Up podcast. My name is Dami. I'm your host with the most, and I'm not doing this alone today. I have my amazing co-host right here.
Hello everyone, my name is Adeolua. Dami, I'm elated to do this alongside you.
Yes, absolutely. And today we are talking about diabetes. Very happy today that we have no other person that will take us through this chronic condition called diabetes. Here in our midst is a doctor, a consultant, a physician, endocrinologist at the National Orthopedic Hospital, Igbobi, Lagos State, Nigeria, and she is a fellow of the West African College of Physicians. Ladies and gentlemen, at the drum roll. In no further introduction, please welcome Dr. Nkem Okoli. You're welcome,
Thank you. Thanks for having me.
Thank you so much. How do you feel being the first guest of our Live It Up podcast?
Oh, I'm honored.
And you're a woman.
Oh, yes.
Women supporting women. Thank you so much, ma. It's very interesting to know that you are an endocrinologist. I mean, that means you actually, after your medicine school, you actually went to go and...
Yes, went back to grind.
Yeah. I mean, that's a lot of years.
Yes.
But how did you start this journey and what inspired you to study endocrinology?
Okay, so, I mean, you start with medical school, right? Before you can get into medical school, you have to pass your JAMB exams, right? And then get into medicine, you have to have good scores. It's 6 years in medical school. But while I was in medical school, we had various strikes. So that lengthened my stay in school. So you graduate and you go for your mandatory 1 year house job. After your house job, you have to do your 1 year youth service. And after your youth service, you can start working, anywhere as a medical doctor. But I went on to continue with my training into residency as in the internal medicine department. And after my part 1 exams, I went on to train as an endocrinologist in the endocrinology unit. And what inspired me to do endocrinology at the time was because of my trainers. There were people that I admired. There were people that, motivated me. They were very nice to me. They could, you could communicate easily with them, take your problems with them. So I still want to say thank you to Professor Chineye and Professor Unachuku for being such fantastic mentors, to me in University of Port Harcourt Teaching Hospital. Right. So, that was it. So yeah, long years. So you have 6 plus 6 years plus X years medical school, counting your strikes.
Shout out to you.
Yeah.
Shout out to you.
So,
that's
and then
amazing.
Your training would take about 5 years. So that's it. And then,
Wow, shout out to you. Thank you so much.
Yeah,
thank you so much, ma. So yes, let's enter. Let me put my head for...
Dr. Okoli, so consultant endocrinologist, I'm sure you're the perfect fit for this job. In a nutshell, what is diabetes? The layman wants to know what diabetes. Some people know it as high blood sugar. They want to show that they don't have sugar running through their veins. They want to understand what diabetes is. What is diabetes?
So basically, diabetes is a chronic condition that is characterized by high blood sugar levels. So those that think it's high blood sugar, they're actually right. And this could occur either from lack of insulin, which is the hormone that regulates your blood sugar, or the insulin is present, but it's just not sensitive. The cells are not able to use it properly, and this results in high blood glucose levels. And those high blood glucose levels, when they occur, they can cause damage to various organs. Basically your eye, your kidneys, your peripheral nerves, especially your peripheral nerves in your lower limbs. Could also cause damage to the heart and to the blood vessels, right? So that's, in a nutshell, that is what diabetes is. And then you have different types of diabetes. So the most common diabetes is a type 2 diabetes, which has a prevalence of 90 to 95% of patients have type 2 diabetes. And then you have type 1 diabetes. So type 1 diabetes is that diabetes that is usually diagnosed in childhood. You see it in children, in very young people. And this group of people do not produce insulin. So this group, if you want to manage them, you have to give them insulin to regulate their blood sugar levels. But in type 2 diabetes, it's that diabetes that is usually diagnosed later in adulthood, even though now you're finding it in some young people, and that's just basically because of some of the risk factors that we're finding in that group. So type 1 and type 2 diabetes are a major type of diabetes. Then we also have diabetes that can occur secondary to other conditions. It could be medications, it could be some other autoimmune diseases, it could be other things, but that is your type 3. Then yes, you have the one that could occur, gestational diabetes mellitus, that you would find in women who are pregnant. So in a nutshell, those are the types of diabetes we have.
Right. Well, you mentioned earlier that there are some risk factors. Can you elaborate on that?
So yes, there are risk factors to getting diabetes. One of the major risk factors is family history. Family, especially for first degree relatives. So when I say first degree relatives, I mean like your mom or your dad, right? So if your mom had diabetes, you have a higher chance of having diabetes. If your dad has diabetes, you have a higher chance. And even both of them, if they have it, it's even doubled. Your risk factor for diabetes is even higher. That's one. Secondly, obesity. Obesity is a big risk factor, especially for type 2 diabetes, because in obesity increases the risk for insulin resistance or insulin insensitivity, which is what you find in type 2 diabetes. Physical inactivity, when you don't exercise, when you have a sedentary lifestyle, you're also prone to type 2 diabetes. High cholesterol levels. In fact, that's even a major thing you have to target for treatment for patients who have diabetes. We've talked about diabetes I've seen in pregnant women. Women who have diabetes while they're pregnant, even after they have their babies and their blood glucose levels return to normal, about 50% of them are at risk down the line of diabetes. Also, patients who are hypertensive are also at risk of diabetes. And then even just being black is also a risk factor for diabetes. Advancing age is also a risk factor for diabetes. And then there's an intermediate group that we call pre-diabetes. So those group of people are also at risk of developing type 2 diabetes. So these are some of the risk factors for diabetes.
Right. So how do these diabetic patients, how do they get treated?
Now we don't really say diabetic patients anymore because of the little stigma. We say people living with diabetes. I'm sure you would have noticed that.
I'm sorry, people living with diabetes.
Yes,
not diabetes.
Not diabetic patients.
I apologize.
Yes.
People living with diabetes.
Yes.
So how do they get treatment?
Well, the important thing is if you're diagnosed, and you're diagnosed by a medical doctor, not by a herbalist, right? If you're diagnosed by a medical doctor, then there should be a plan for management. So management of diabetes will be non-pharmacological and pharmacological, meaning that there's management that doesn't have anything to do with medications, and then there's treatment that involves use of drugs. So when we talk about non-pharmacological, we're talking about one diet. You cannot manage diabetes without managing your diet. So the people living with diabetes have to cut down on their refined sugars. What you find in your cakes, your ice cream, your pastry, your sodas. Most times you'll say, oh, I don't have any energy, and then you gulp down 3 bottles of Coke. So that's maybe like 60 cubes of sugar because you have about 15 to 20 cubes in a bottle of soda. Yes, that's what it is. So that's a huge thing with your diet. So we talk about exercise, because when you exercise, it will help you to lose weight, and it will also help your insulin insensitivity and help your cells to take up the glucose better. So we talked about diet, we talked about exercise. Those are the major things when you talk about the non-pharmacologic treatment of diabetes. Then again, one of the most important things that I've not said is education. You must educate your patients, your people living with diabetes, on the condition. Because when you don't educate them properly, they take medications just for a short while and then they leave it. Because diabetes is a progressive disease. That's the first thing you must tell them. At the time they are being diagnosed with diabetes, they've already lost 50% of the cells that help them to even produce insulin. And as the years go by, they're going to need more medications. They're even going to need injectables to control their blood sugar. So every person living with diabetes must be told by their doctor that diabetes is a progressive disease. Education is key to management, right? And then you have pharmacological, where you have to use drugs, where you have to use injectables. Some of the drugs are taken orally, that's through the mouth, and some come in injectable forms. So that's it on Trixton.
Dr. Okoli, I like the fact that you've been able to dissect it properly, and I know that you're the best fit for the job. You're a consultant, you see patients every day, you understand the disease. I would like you to tell me what's the prevalence of type 2 diabetes in Nigeria. How do we know that there's a burden? Is there a burden?
Oh yes, there's a huge burden. There's a very, very huge burden. And again, you know that our health facilities are not where it should be. So, I mean, we're in a big city like Lagos, so it's not going to be too difficult for someone who's diagnosed here. But what about those in the rural areas? What's the access to health facilities at those points and in those areas? Right? So there's a huge burden. In Nigeria, most of the studies will give a prevalence of, say, 4.7% of the population having diabetes. But there was a recent study that was done by a group of researchers that found a poor prevalence of 5.77%. And the important thing to note is that the prevalence is increasing every time. Every time you go back to look at what the prevalence is looking like, it's increased. In fact, by the time you're getting what the prevalence is worldwide, according to IDF, by 2021, we had about over 500 million people in the world living with diabetes, which is projected to increase to 724 million by 2045. And by the time you go next year and look at the prevalence, IDF studies, you will notice that it has even increased past 700 million. Probably 2045 might now be 800 million. So yes, there's a huge burden. And they're talking about, because it is a chronic disease, you have to look at cost of medications.
Yeah.
And when some of these people are coming late, diagnosis will make them come with complications. So treatment of complications too.
So Dr. Okoli, please, what's the importance of testing? Why do I have to test my blood sugar? Why do I have to know my numbers? I need you to stress on that.
So now you have to, we can answer that question in two phases, right? Yeah. So you have to test yourself if you are not diagnosed already, especially if you have any risk factors, right? So if you're someone who has a strong family history of diabetes, you should start early to do your test annually. And it's not even enough to just do your fasting blood sugar. You also have to do a test we call the HbA1c, which we can use to diagnose diabetes, and also it tells us what the blood sugar has been like over the previous 2 to 3 months. So a lot of patients will go and say, "Oh, doctor, I did a fasting last year and it was normal."
Last year.
Yes, but you know what they don't know? Like I said, diabetes is progressive. So when the problem first starts, right, your pancreas will start to say, "Okay, guys, we need to go insulin. Let's increase. We have to make sure that the blood sugar is normal." So it starts, ramping up and trying to do better. But when you're ramping up and you're overstressing yourself, what happens? The next thing, you start to get a little bit weaker. And then when that happens, that's when your fasting starts to go up. So this is just to say that by the time you're even diagnosed and your fasting is high, you've probably been diabetic about 5 years before. So that's why it's important to also do the HbA1c. So that's for those who have not been diagnosed. Now, for those who have been diagnosed, you must know your numbers. Because you must know your numbers, because you need to make sure that you are you're within the range that you should be for your blood sugar levels to be normal. Because if your blood sugar levels are not normal, you keep yourself open to complications of diabetes, and that's not what you want, right? So that's the importance of knowing your numbers. You must monitor, which is a very, very key aspect of management of diabetes. Yes.
Have you tested yourself?
I think every black person should test. She said that being black is a risk factor.
Yes, it is.
Risk factors. Everybody in Nigeria, walk into any medical store, you get tested.
That's it. Walk into any med plus store and get your blood sugar checked. After this whole test has been done, how can I certify that I'm diabetic? How do I know that I'm diabetic? I know you had mentioned this. Yeah, because man, let me not lie. I don't take sugar, but my weakness, like I'm very concerned or very particular about my sugar intake. And no, that was coming from a different distance, because in my family we are very, so I don't want to take too much sugar and go and occupy space. so I'm very particular, but I always notice that when I don't, I'm extremely weak. Like, I can't even climb the stairs. Like, and then when I try to take something,
you feel better.
Yeah, I feel better. So I don't know. Ade is my friendly pharmacist. He will tell something about being hypoglycemic or something like that, But that's a different question. But the question I want to ask is, how do I know that I'm diabetic? And how do I know that I am not, even with the test?
Okay, so good. So when you are diabetic, there are certain symptoms that you could present with. So type 1 diabetes, which is the type of diabetes you find in childhood and in very young children, usually would present with the salient symptoms of diabetes. So you find yourself, you're always drinking and always getting thirsty. That's number one. You're drinking large volumes of water. And as you're drinking, you're passing large volumes of urine. Another thing is that you notice that you're losing weight despite the fact that you're eating a lot of food. So those are the 3 cardinal features that you would find in diabetes. But usually those with type 1, that's the way they will present. Type 2 diabetics may not present with those cardinal features. They may not. And that's why when you see people when I just diagnosed, I say, but I wasn't peeing and I wasn't drinking water. I'm like, no, but this is what your biochemical indices are saying. And so that's what it is. But in those people, you might find that they are presenting with complications. So it's either they can't see well, they notice that their vision is getting blurred, they notice that they're waking up several times at night to start passing urine, or they might have a wound or they injure themselves and the wound is taking months and months and months to heal. So diabetes causes slow wound healing. Some of them may tell you, they've been having a lot of boils, or they've been having a lot of urinary tract infections for the women, or they might notice some tingling in their hands and feet, which will be from affectation of the nerves. So most type 2s will come with complications. That is not to say that some of them cannot also still come with those cardinal features, because those are your cardinal symptoms. Some of them could come in acute complications, where they come into the hospital to the emergency, their blood sugar levels, in fact, it's unrecordably high. You don't get a value. So when you say unrecordably high, it's already above 35 millimoles per liter. And then they can come with severe infections, they can come with bacterial infections, they can even come unconscious or in coma. And that could be the first time they were being diagnosed. Yes.
Right. So sorry, Ade, before you come in, so what's it take for this particular question? Always get yourself tested, right?
Yes, the take from this is that if you have a family history and you have other risk factors like obesity, being overweight, you have a sedentary lifestyle, and you're at least 35 years, you must check your blood sugar. You must do that annually, in addition to your HbA1c. And don't say, I've already eaten today, I can't go and test myself. No, we also have random values that include you as diabetic or pre-diabetic.
HbA1c.
So it does, yes, your HbA1c.
Yeah.
Interesting. Dr. Okoli,
Yeah.
You've done amazing work really well. I'd like to know, how can I avoid my complications? What are these complications first and foremost? What are these complications and how can I avoid?
So the various complications that we've talked about is 1, affectation of the eyes. And when the eyes are affected, you find out your vision is blurred. And this can even lead to blindness.
Wow.
Diabetes affects the kidneys and it can cause chronic kidney disease. Diabetes is one of the commonest causes of chronic disease worldwide. Diabetes can affect your peripheral nerves, your nerves in your feet that tell you when something is hot, when something is cold, can affect it, and then you can have tingling sensation. Also, diabetes predisposes you to high cholesterol levels, right? Insulin resistance causes increase in cholesterol synthesis. And when this cholesterol comes, it can plaque and lay in the vessels that supply your feet with blood. And when that happens, blood flow to the lower limbs are reduced, to the legs are reduced. No, you won't die, but what will happen is that, yes, exactly. So what happens is that you have a wound, the wound is not healing. You start having numbness, you start having tingling, right? So those are some of the complications you can have from, having diabetes.
So like, how do I avoid to make sure?
So how you can avoid is to stay adherent and compliant to your treatment. So how can you avoid is adhering to treatment, adhere to your pharmacological measures, to your non-pharmacological measures of management. That is how you can prevent your complications. Monitor your blood sugar regularly, because if you do that and you're in the target range where you should be, because your doctor will give you your target range. Diabetes management is individualized. Every patient's management is different, right? What I would do for a 75-year-old who will be coming with other problems is not what I would do for somebody who is probably 45, right? Because someone who is 45, I want his blood sugar levels to be as close to normal as possible. But somebody who is older, you don't want his blood sugars too tight, because you don't want him to get hypoglycemic.
Yeah.
Because he might already be having what we call hypoglycemic unawareness. He might not even know when he's hypoglycemic. So it's different for different patients. But the important thing is that if you want your complications as far, you don't want them, then you have to make sure that you're adhering to therapy, which includes your diet, which includes your exercise, which includes monitoring, and which includes seeing your physician regularly. Some patients will tell you, oh, doctor, but I was taking my drugs. It's a progressive disease. So there's a transition time that would come when the medications you're taking is really not controlling your blood sugar. Yes, to an extent. Yes.
So at some point, the medication won't work anymore.
It's a progressive disease.
Wow.
So the cells you had at a certain time doing better, you may not have that population anymore. So at that point, you have to start bringing injectables like insulin to help to give you better control. Yeah.
Right. Amazing. I think I'm learning a lot. Just want to ask one question. So these complications, do they, because you mentioned about type 1 diabetes, and then some children may even have it. So this complication, do they differ, let's say, by type, and then the children that have it, that maybe got it from, is it
Yes,
different?
there's a bit of difference. I mean, in young people, you may not find cardiovascular complications like hypertension, like high cholesterol levels, like strokes, like heart attacks. You might not find that in very young people. In fact, usually when you're diagnosing them, you may not find complications. But for patients who are type 2, usually they might already be coming with a complication, because remember we talked about the intermediate phase of which they've even been exposed to hyperglycemia for a long time, even before diagnosis. Yes. So for younger children, you may not find cardiovascular problems, but you may find things like slow wound healing. You may find things like recurrent infections if their blood sugar levels are not well controlled.
All right. Thank you so much. I don't think I mentioned this, so please do know that this Live It Up podcast is supported by our partner, a pharmaceutical company called Pharma Symbiosis Nigeria Limited. Please, a round of applause for them. They did well. Thank you.
So Dr. Okoli, brings me to, you've been talking about refined sugar, you talked about saturated fat and all that stuff. But some people, you go out with your boys, you take 1 or 2 shots of tequila, vodka. This thing is not sweet. So I'm not taking
Refined sugars.
I'm not taking soda. They'll tell you that soda is JD now. You'll take so 1 or 2 glasses, maybe every fortnight, every week. Would it hurt? I take for someone that takes alcohol.
Okay, so I think the key is to be moderate with your alcohol consumption, because alcohol does also increase your risk for insulin resistance. Also, if you are someone that you binge on alcohol or you take alcohol a lot, you could actually predispose yourself to chronic pancreatitis, which can result in diabetes. And alcohol itself, it's sugar. And apart from that, it increases, it has a lot of calorie and can make you put on weight. And most of the weight might be around, thank you.
No more
That's
alcohol.
gives you risk for insulin resistance, which eventually will go to what? Diabetes. Exactly.
Right.
So you must be moderate in your consumption of alcohol.
Well, talking about alcohol and dieting, there's this thing that they usually say. For audience that are very traditional, they will use we call it. Let me not use ephedrine scent leaf, ewuro. Yes, that's bitter leaf. They will drink it. They will tell you that. I know someone that does it a lot. Yes. If I take ewuro like this, it would.
To clean everything.
Yeah, cleanse my system. And these people, they have a family history of diabetes, but they are so confident in their traditional and natural remedies. Yes. So what do you say about that?
Well, it still won't replace your medications if you are a patient living with diabetes.
Well, will you do the work?
I mean,
Like maybe
the
bring
good
down
thing
the-
is that bitter leaf has what we call a low glycemic index. So the glycemic index is that thing that that certain foods have and tells you how high it can take your blood sugar to. So bitter leaf has a low glycemic index, so it's not going to really spike your blood sugars, but that's not the treatment for your chronic condition.
So you still in that pharmaceutical.
Oh yes, because you still need to be on your medications. It's not your medication, it's not going to replace that. But if you're on foods like that, it will help you to control your blood sugar because it doesn't have a high glycemic index.
Right. Okay. So now I want to go into this very interesting aspect of this conversation, is the myth surrounding this chronic condition called diabetes. I mean, growing up, we've heard a lot of things. I personally have heard that I'm a woman, I'm a lady. So if my father had diabetes, there's a high chance that me as a girl, I will have, and my sisters will have. But if my mom, the son might not. If it's only my father, the son will not have. But the girls in the family will have. But if it's the mother, the boys will have. And then, so how true is that?
Well, that's definitely a myth because studies have shown that if your mother has diabetes, she sort of gives you a higher risk than your father. But it's not particular to whether it's boys or girls. The truth is that there's already a risk if your parent has it, yes. So that should be a myth,
Another
yeah.
myth I know is the fact that if you pee, sugar, if you pee and there are ants around your urine droplets and all that, and you see ants, then you're diabetic.
Yeah.
Is that-
Well, the truth is that if you pee, I mean, in those days, I'm
That's
sure a
what-
lot of the
That's you being dirty. You go and pee outside and ants will be surrounding
No,
you.
that's you hear these things among like very
yes, that happens. That actually happens.
I think that's where the Yoruba people got
That actually
sugar
happens
from.
for people living with diabetes who are not well controlled. You're actually losing a lot of sugar, glucose in your urine. So I'm sure if you do that outside where you have insects, that's going to happen, right? But you're not going to wait till you do that outside to diagnose yourself, because now most people are actually doing that in proper restrooms.
Okay.
Yeah, good.
Well,
So
I think we should
yes.
improve my diet because refined sugar, I don't take alcohol, I think we should improve my diet.
Oh yes, there are ways to improve your diet. The important thing is that you have to eat healthy.
Eat rice, eat
But
bread.
that the word, like, I think health is relative because
Rice and
you say you're eating balanced diet. What you look at rice alone is
chicken.
I think the important thing to note is stay with the right proportions. Get
proportion
better
control.
options. Instead of eating, for our patients living with diabetes, would advise them on eating white bread, eat wheat bread. Always get better options. And then even if you have the wheat bread, you can even toast it. That was yes. The
What
rice, like your father rice, it has more fiber. It's healthier than your refined rice.
Wow.
But it's not that you eat the ofada and you
One and
eat the
same.
one that can fill a bucket. So it has to be, or always have,
No, let me
you know,
report I did to you before we came here. If you see at this plate like this,
I was hungry now.
With chicken.
I don't think it will affect my blood sugar.
jollof
Anyway,
rice
he's
with
still-
chivita juice.
he's still leveraging on his age, but you have to also watch it because this is chronic,
And I'm
and
not
then
obese.
it's years of unhealthy living that usually result in these things. Exactly. So basically, you have to have a healthier diet, more fruits, more vegetables, olive oil for those with high
But
cholesterol.
sometimes this is actually increasing the burden of the disease because I think it's less expensive to eat unhealthy than. I mean,
Well, yes, that's what we say most of the time, but I think it's still not so expensive to eat healthy, especially if you're going to, leverage on a lot of green vegetables. Eat seasonal fruits.
okay.
You don't be looking for things like
Pineapple.
garden eggs when no, that is not
Yeah,
pineapple.
pineapple doesn't-
Pineapple has a lot of sugar. So if you're not
What we
not
night
if
now?
you're not a person if you're not a person living with diabetes, you can have them, but not, I mean, you're not going to eat a whole pineapple. But for people living with diabetes, pineapple is not really the best choice in terms
So
of
what fruits
So
will you
so
recommend?
you want to recommend things like fruits that have a lower glycemic index.
So I think it's best to just maybe you set those foods, then know what they are, and then go for them.
You can have cucumbers. You can have garden eggs. Yes. You can have loads of green vegetables. You can have,
So no more chicken.
no, you can have chicken is fantastic. It's protein.
Beef.
Beef is good, but then again, you have to watch your saturated fats. Beef has a lot of cholesterol. So I know that we're not eating steak, we're not eating a whole plate of beef. So I'm usually not going to.
I will put Dami can eat like the whole.
Are you high?
Mashed
Where?
potatoes and.
But you know, mashed potatoes comes with a lot of butter, comes with a lot of full cream milk.
when did you see me eating mashed
So
potatoes?
you have to watch. You have to watch those things. Yeah.
I want to talk about the financial burden. I mean, this chronic condition can be very exhausting, you know, when you have to spend a lot. You spoke about injectables recently, and I know that there's this particular injectable, will I say that is popular but is very expensive and is even a bit scarce now. So what do you want to say about when the financial burden is too much for people that cannot even afford it, but they still have to go through their treatments?
Okay, so the important thing is that when you see your patients, you have to sort of classify your patients. You have to ask, when you're giving drugs, you have to ask about what they can they afford. You don't want to give them drugs that they cannot afford. We still have diabetic medications. We have tablets and oral medications that are not as expensive as others. Do you understand? So in treating your patients, cost of medication is key because it's chronic and it's something they'll be taking almost for a life, right? So you don't want to give them medications that they buy today and tomorrow they cannot afford to buy it anymore. So you must know what the patient can afford. You must know how much a patient has that is, available to buy medications. Because remember, like we said, most of these patients are coming, it's not just diabetes. They may be hypertensive. They have high cholesterol levels and they have to be on statins. They might have so many other problems and those things need to be treated. So you must classify your patient's pockets and know what the patient can afford. And what the patient can afford is what you should use for that patient. Do you understand? Exactly. Even though it's important too that when we're classifying our patients, we want to know, do they have other cardiovascular diseases? Have they had heart failure? Do they have renal failure? To determine what kind of medications to give them. But the most important thing that is key is that you're not going to give a patient medication the patient cannot afford because it's a chronic disease, and you want to make sure that that patient is on medication and the patient's blood sugar control is target.
Right. Thank you so much.
So you must ask that question.
Dr. Okoli, I have interesting questions from our audience.
Oh, yeah.
I read them and I know that if you answer them, you will also teach me.
Okay.
Okay, so it says, why do some doctors prescribe metformin tablets for borderline sugar values while others don't? What would you recommend for borderline values?
Okay, so now the thing is that we talked about pre-diabetes, which is an intermediate phase before you have type 2 diabetes. So in managing pre-diabetes, it's neither here nor there because, like I said, it's an individualized therapy. You must look at the patient in front of you. What are those patients' risk factors for pre-diabetes? Pre-diabetes too is a range. It's HbA1c between 5.7 to 6.4. Now, if I'm seeing a patient who even has 5.7, who is hypertensive, who is obese, and probably has a BMI of more than 40, who has a family history, I would opt to treat that patient, right? Yes, and start metformin because it may be different for somebody else. So those are the important things to note. You, like I said, what you're presenting with is not what another person is presenting with. There are some patients that you see who would also come in with pre-diabetes, who you might opt to say, you know what, go for lifestyle modifications, which includes your diet, which includes exercise, which includes weight loss, and let's see you in another 12 weeks. And let's repeat your HbA1c and repeat your other indices, and let's see where you're at. So it depends on the other problems you're coming with. It depends on your risk factors. Depends on the patient in front of you. Is it an individualized therapy? Yeah.
So this next question is, I like to know what the answer would be because I think some patients don't want to take medication. That's the challenge. They don't want to take medication. So you're hearing, can lifestyle changes reverse type 2 diabetes? Like, I don't want to take medication. I would exercise, I watch my diet, but I don't want this medication. Can lifestyle changes reverse type 2 diabetes?
It depends on when you're presenting. There are studies that have been done. There are landmark studies that did show that there was some reversal with onset of strict adherence to lifestyle modifications and even low dose metformin. But most of those patients are probably patients who will still be pre-diabetic. Do you understand what I'm saying? Exactly. So yes, you can have lifestyle measures, reversing it and putting it in remission. Doesn't mean that later your blood sugar levels may not come up.
Okay, I get it.
Yeah.
Some people say wheat is better for diabetes. I think person means wheat bread. Wheat is better for diabetes.
Or even your
Patients-
swallow.
People living with diabetes. Others say wheat is not safe. Which is the right one?
So wheat doesn't have a very high glycemic index. I think the important thing to note is that if you're going to get your wheat, probably want to get the raw thing and you want to grind it yourself, so you know what exactly the contents of what you're buying are. Because sometimes you're getting some of these things, they're already ground and you don't know what the other additives are in them.
Right. Okay. So still on the Q&As from our audience, someone is asking, how do you manage gestational diabetes? Did I get it right?
Yeah. So gestational diabetes is diabetes that is diagnosed in pregnancy at any time. So the way to diagnose gestational diabetes is that we have certain indices, biochemical indices that we look at. So we diagnose it when the fasting blood sugar is between 5.1 to 6.9, and when the 2-hour post-glucose load is between 8.5 to less than 11. But if you're more than 11, we don't talk of gestational diabetes anymore, because that includes you as a diabetic patient. So we say you have diabetes in pregnancy. And when the fasting is more than 7, we say that you have diabetes in pregnancy. But when you fall within these ranges, we talk about gestational diabetes mellitus. And of course, you have to be seeing your doctor, who will now know how to manage you. Mostly in this environment, for patients who may need medication, we usually would use insulin.
Right.
Yeah.
So another question, what quantity of carbohydrate should be consumed by a person living with diabetes?
I think that person will have to be referred to a dietitian. You need dietary consults, because as much as that is one of the key factors or one of the key roles in management of diabetes, you must see your dietitian. The dietitian will give you proper education on your menu, on your carbohydrate contents, and then they will tell you what best options to use for things like your swallows, other options you can use that you don't even know about, how to make your pap and not just use yellow pap, but to use portions of your millet, your guinea corn and your pap, and then put it together. So you have something that will not be spiking your blood sugar level. So this person needs proper counseling and education from a dietitian. Yeah.
And then can an athlete have diabetes?
Yeah, why not? What's stopping an athlete from having diabetes?
Exercising every day.
Oh, yes. Well, we don't know the athlete's other risk factors.
Yeah.
Oh, yeah, we don't. Yeah.
Okay. Thank you so much. My brain has,
Saturated.
yeah, with a lot of things. But this is a personal question, and I believe that people would also want to have this kind of question. What supplements can a diabetic patient, can people living with diabetes use? Your vitamins and all of that.
Okay, so now people living with diabetes, we have supplements that we give that can help, right? Right from supplements for people who may have complications with affectation of their peripheral nerves. There are supplements that we give. Alpha lipoic acid is one of the supplements. Vitamin D is also a good supplement for our diabetic patients, and some of the other vitamins. But sometimes some of our patients living with diabetes, they come with a whole bunch of carton. They come with a carton food with all sorts of things. So you have to look through it and figure out what they can take and what they can't take. But yes, vitamin supplements are okay. Vitamin D especially. The B vitamins are usually key because they are good for the nerves. And it's very good for the nerve health. And then alpha lipoic acid supplements are quite good. Oh, yes.
Right. Thank you so much for gracing our chair.
Thank you for
Thank
having
you so
me.
much for giving us this body of knowledge. And then to our amazing listeners, this is a lifestyle brand. You can walk into any MedPlus store, speak to your pharmacy on more knowledge about diabetes. And you can also follow us on all social media platforms. On Instagram, it is MedPlus Pharmacy NG. On Twitter, MedPlus Pharmacy. Same on Instagram. The Live It Up podcast is the Live It Up _pod. This broadcast would be uploaded on our YouTube page at MedPlus Pharmacy Limited. Oh, it's so sad that we have to cut the curtains right now. Thank you so much.
Thank you for having me.
Had so much fun. No, I used to say that health is boring, and I said it like a couple.
No,
yeah, this
health
wasn't.
isn't boring, actually.
Okay, doctors are boring.
No. I take personal offense to that.
no, but you're not boring. You're a very funky doctor. Don't worry. You're my paddy now. We're best of friends now.
That means also leave it up.
Oh yeah. We have so leave it up. Let me say inside joke. Leave it up is like is a slogan for we Med Plus staff. So when we say Med Plus, we say leave it up.
Okay.
Yeah, Med Plus, leave it up. So the Med Plus is 30 years. Well, 31 this year. And the whole idea about Live It Up is irrespective of how many years we've been in the business or whatever situation you find yourself, you just have to live it up, leave all those bad energy and just live life. Yeah. So that's the whole idea of Live It Up. So when I say Med Plus, you say Live It Up. Med Plus,
Live it up.
Med Plus,
Live it up.
When I say Live It Up, you say podcast. Live it up.
Podcast.
Live it up.
Podcast.
Thank you guys. I am Dami. And remember to live it up.